Welcome to the Healthcare Leadership Experience, a place where healthcare leaders will share proven strategies and innovative approaches to leading the clinical and business side of healthcare. This show is sponsored by VIE Healthcare Consulting, who has proudly helped hospitals save over $700 million in non-labor costs since 1999. Here's your host, Lisa Miller, founder and CEO of VIE Healthcare.
Hi, this is Lisa Miller, and I have a special guest today on the Healthcare Leadership Experience. I have Rich Dormer, Bryan Covert, and Pandu Mitre from the VIE team. So we're going to have a conversation about purchase services, and really specifically around, are you getting the best pricing or really a false sense of security? And there's a couple of different components to the conversation today, as it focuses around where we look to for cost savings, or what some of our metrics are for our cost savings, and just maybe some of the assumptions, or some of the areas that we consider not opportunities for savings. And so we're going to address those four particular areas we're going to talk about in more detail. We're going to talk together with this team, amongst there's a few other of us of my team who aren't here, but who work on purchase services. But I've invited these guys into the conversation today, into the podcast, so we can just talk through these four areas of maybe avoiding that false sense of security and really preventing missed opportunities. Because I'll tell you what, we continue to work in this purchase services space, and there are just some significant opportunities, and these are opportunities that we're achieving even after some of these have been reviewed as no-cost opportunities, no-cost savings opportunities, or been reviewed because they've been benchmarked in other places. And it's still a ripe area, particularly now, with the challenges we're faced with the pandemic. If you really want to go and cover cost savings, I would really go back to or go deeper into purchase services. So I want to start off by asking Rich Dormer to jump in and talk with us about the categories in purchase services, because it's an interesting space. Rich, if you can give us those 6 categories, those 2 that most people really don't look at, and maybe some examples within the 6 categories. You just give the audience some ideas of what is a purchase services spend.
Great. Thank you, Lisa. And again, the 6 categories on how VIE separates out the different purchase services. We have one is clinical services. Could be something like wound care, lithotripsy. Facilities and support services is the second category. This obviously ties into any of the HVAC, and then any of the supply chain services and applications that are used there. Then you have the third category is finance, HIM, rev cycle. You have the ICD-10 coding, outsourced coding, and any of the debt collection and any of the types of financial tools that are being utilized. Then you have biomed and service and maintenance as our fourth category. So these are the clinical equipment services, as well as any type of service that's being applied to any equipment in the clinical areas. And then our fifth category is IT, telecom, telehealth, and obviously your traditional telecommunications services, but also from IT, you have a lot of the systems that support the organization. And in the bigger areas that's been increasing a lot recently, especially with COVID, is a lot of the telehealth and tele-ICU and telestroke. And then our sixth category is administration and HR. And, a lot of the workforce management solutions are under the HR. And then as far as the administration, one of the biggest areas that we're seeing recently is on the physician services side. And, as far as the groups such as you'd see anesthesiology, emergency medicine, pathology. And another area under this is joint venture agreements, specifically a couple of recent ones that we're working on, radiology, wound care, and these agreements are really complex, and, to just look at an agreement and determine if there's opportunity is really just impossible. It's the same with just looking at the invoices. There's a lot of information that needs to be collected from the P&L, net patient revenue, and also some of the professional compensation benchmarks that are really critical to look at the entire picture and understand what the opportunity is. And then obviously, there's the ability to, negotiate the best pricing and the best fees and the best subsidies. But all that is important to, obtain from those critical financial drivers.
Yeah, thank you, Rich. And I want to point out that a lot of these areas, as you go deeper into purchase services spend, and as you start looking at some of those outsourced physician services like you talked about, the JV agreements, they become real complex. They need expertise. There's these deep financial forensic reviews. It's deep expertise in knowing these services and all the components that need to be analyzed. This isn't a linear analysis. It requires a lot of understanding of where the money is flowing to and from, and the expertise to understand those services and how they may interact.
Right, and based on the number of OR rooms and available minutes, as well as, what is the underlying hourly hours that you're using to come up with the compensation baseline. These are the things that, if you're just shooting in the dark, you go to have conversations with the physician groups and the leadership there, you're not going to get anywhere. You'll be laughed out of the room. So it's important to understand really what are the critical drivers and put the plan together, and then collectively get the buy-in from the organization. But just because these agreements, these relationships are very important for organizations. Obviously this is emergency medicine. This is your emergency department, leadership. This is pathology. These are the leaders within the organization, but they're also purchase service. It's an outsourced agreement. So there's a lot of sensitivity around them as well.
Yeah, and I just want to make one comment about that. Sometimes organizations like us to come in, particularly around these physician outsourced agreements like you mentioned, or JV, because we get to not only do those forensic analysis, but do the those reviews on subsidies, reviews on compensation or services, but we also get to be that buffer. Because hospitals need to look at those agreements, and you want to compensate for those services and certainly compensate for them well. But there is also a requirement that these agreements have a deeper audit component to them, and they need to be fair market value. So they need to have an annual review. But it also puts that buffer because it allows us to then be talking to the physicians and doing the negotiations and asking the questions and really providing those services and, kind of helping the hospital maybe stay out of it a little bit. And, the hospital's got to ensure they're paying fair market value pricing on these agreements. And sometimes it's better to have an independent consultant or a firm that's helping support the hospital in these arrangements and this analysis. And so we've seen that's been very helpful for hospitals and, having us in the process. So I'm going to jump right into this whole conversation of, are you getting the best pricing, or is it a false sense of security? And, we've been talking a lot about this to our clients, and there's 4 areas of really where we want to explore. And, this conversation, again, is specifically relates to purchase services. And so the first area is GPOs. And, GPOs are a valuable part of our ecosystem in healthcare. They are definitely important for hospitals. And I often say is that there's going to be a various pieces of the puzzle or tools in the tool set for hospitals to use for their financial improvement. And, GPOs are one of them. They're not the only one. Many should be used. There's a lot of great innovative companies that are providing ways for hospitals to look at their agreements or look at their spend or look at value analysis. And I encourage hospitals to really look outside of their GPO for additional second opinions and advice. But in purchase services spend, it gets very tricky because a lot of these agreements aren't, the hospitals aren't getting the best pricing. and because we think, well, they're on a GPO agreement, it's the best pricing, we might get an admin fee share. But many times that we're seeing a lot of issues as it relates to getting best pricing because they are very regionalized in nature, very service oriented, and a lot of those price points need to be done really at a hospital or health system level. And I know, Bryan, you work on quite a bit of these agreements, whether it's EVS or dietary or where you've seen them on a GPO agreement, and it really has cost the hospital quite a bit more money versus having their own independent direct agreement.
Yeah, that's exactly right. It's extremely difficult to negotiate a one-size-fits-all purchase service agreement, especially in those areas that you mentioned, EVS and food services. Oftentimes what happens is, if we look at food services as an example, some of the broader terms will be negotiated. The GPO agreement might cover what your food cost share back is, or it might limit a fringe rate benefit. But if you're not looking at the customized service requirements of the location, and you're not looking at the profit and loss statement as a whole, it becomes easy to cost shift, to put additional costs as direct expenses. There's no possible way to do a one-size-fits-all agreement for food services that can fit, all of the unique requirements of each individual location, and do so at a, best in market or competitive rate.
Yeah, I think you've had two different conversations. You had shown me where there's a bucket of spend in the dietary. It's like a catch-all, and where money kind of gets moved around. But this catch-all really ends up being a place where you particularly dive in, and you really require this catch-all bucket to be itemized.
That's exactly right, and that's looking at reimbursed direct expenses. So I gave the example previously of capping fringe benefit rates, but if a particular location, a vendor is unable to meet that, they can take components of those rates and put them through as a direct expense, whether it's some kind of insurance premium or employee training or anything that could be argued as a direct expense, some component of a healthcare premium or anything like that can be put through as a direct expense, and they can still meet that required broad fringe rate benefit that the national contract requires.
Yeah, and I don't know, we don't go in a whole lot of detail, and the admin fee share, is an aspect of the GPOs of the safe harbor, so the hospitals can get access to contracts that they have negotiated in scale, the pricing exists, and so that admin fee share from the vendors is shared to some degree with the hospitals, depending on the arrangement. But we've also found where those admin fee shares or the admin fee costs on a dietary agreement, or example, really could increase the cost because they're passing that cost through.
Yeah, and that's exactly right. So if you are negotiating your food service agreement and you push for an itemized P&L and you look in your direct expense buckets, you'll see that these providers are building it right in typically, or they're putting it in some administrative bucket, administrative overhead cost. And if you ask for specificity there, they'll share with you exactly what those costs are. You may have to push for it, but typically dollar for dollar, whatever GPO fee they're paying is built right into your profit and loss statement. It's built right into your expenses. So you are paying for that.
Right. And, Bryan, thank you. And, it's really about these service agreements that have to be pulled apart, looked at by the detail to really understand what those cost drivers are. And typically these services are very unique to hospitals. Even if you're looking at let's say a dialysis spend, where most people will look at a 1-to-1 rate or a 2-to-1 rate, and think that's all. Bryan, talk a little bit about why that's probably a false sense of security, just looking at a 1-to-1 or a 2-to-1 rate for dialysis.
Yeah, so dialysis is very complex and it's very regional. It's probably one of the most regionally affected areas of cost that you could contract for in the hospital, and it has to do with a number of factors. When we're benchmarking dialysis, not only are we looking at, the volumes in the 1-on-1 and 2-to-1 rate, but we're looking at things that affect those rates and that affect the cost structure of the provider. So, the availability of dialysis nurses in the area, the presence of competition, the specific setup and requirements of the location, what other services are being provided. Do they give adequate space to do 2-on-1s? Is it all bedside? So there's so many different factors that go into a dialysis rate. It's nearly impossible to, just look surface level at a 2-to-1 and 1-on-1 rate and say you're at A, you should be at B, without considering those factors.
Yeah, and I see a lot of times that we're getting benchmarks just for that. I see it quite a bit, and I'm like, wait a minute, that it's not that oversimplified. Like, there's so much more to it, and you did a great job at explaining the other factors. And so, we'll hear, oh, we've already benchmarked our dialysis and we've got great rates. And then we start asking these questions, and then we do, additional reviews, and we're able to identify other opportunities. But that's a great example of where you might have a GPO agreement for dialysis or a regional agreement, but that still needs to be examined as an independent hospital. So thank you, Bryan. Next, we're going to move to RFPs. We love RFPs. We work with many of our hospitals to put together. We have our own methodology in our RFP, which is very streamlined, and it accelerates that time and gets that analysis completed or out to the vendors, and in a shortened period of time. So we think RFPs are great. Whether you go right to renegotiation, because sometimes there's a reason to go right into renegotiation versus having an RFP, but there's certain times when RFPs do matter and they're important. And how we analyze RFPs, or how we really put them together, is also important, because again, just because an RFP is put together doesn't mean you're getting the best pricing. And a lot of times, depending on how that RFP was put together, whether or not your hospital has a 12-month past utilization put together and developed and as part of the RFP, that's key, because if you're only putting in 40% of your spend or only a couple of elements, you're not going to get the biggest value or the best value. And we've had a couple of hospitals where we were asked to kind of jump in to help support the RFPs, and they took maybe a 1 or 2 month sampling, and we went back and said, well, we're going to go ahead and give you a 12-month extensive line item detailed utilization so we can build that RFP so you capture the most value. But Rich, do you want to talk a little bit about RFPs in the sense of just because you put together an RFP does not mean you're getting the best price, and where some of those issues may come up with in terms of an RFP that doesn't deliver the most savings it could.
Right, and you mentioned the historical data and just understanding utilization. Obviously, that's a huge piece in which we see a lot of gaps in some of the RFPs that we've analyzed after they've been done. But you also want to understand the current contracts and the obligations, as well as the optimal goals of why you're doing the RFP. Right, that should be clearly outlined in the RFP, and then that should be developed by really interviewing the internal stakeholders that are requesting the RFP. It shouldn't just be this general template and then sent out. There should be some reason why an RFP is being done. It shouldn't just be defaulted. But then the other side of it is when those bids are coming back and really just getting that comparison down. Now, part of the strategy on an RFP before it's being sent out, is putting all that together in a succinct Excel spreadsheet, Word document, so when the vendors get it, they clearly know how to respond. And the directive is to fill in the specific areas based on the utilization, based on the contract, based on the optimal goals of the organization. And then once that information comes back, We see it. No matter how strict you can be on, filling out information, the vendors either don't understand it or are unwilling to do it. But still, there needs to be that comparison. It's very important, and we do see a lot of times where, that comparison between vendors is not done accurately, just because some of the cost drivers are in the terms and not necessarily laid out in the price file that's sent back. So that's the biggest area that we always see, is to make sure that all of the terms and all of the price files, everything is put together, and then a vetting out process with each of the vendors is important as well, just to make sure and clarify what their intent was and what is actually being communicated in the RFP.
Yeah, I love that. You brought up two good points, is that Frontline Insights, and just because you had a contract for many years and it may seemingly be something that's going to go into renewal, but just getting some feedback, asking some questions. I'm always amazed by when we do talk to those frontline users. Just different issues come up, different facts come up, insights come up that really are very material to negotiating or putting together an RFP that has meaningful financial, operational, or clinical value. So that's really important. The other thing that you mentioned, and I think it's probably the biggest opportunity, is bid analysis, and how you analyze that. The bids is really important, and sometimes we'll create spreadsheets and documents that have to be completed in our format, so the vendors can't complete it in their format, because we want to make that analysis streamlined and as possible. But we also recognize that different vendors will have their own structure, or they're going to put together a model differently, and we've got to analyze that bid analysis. And that's the other opportunity in RFPs, is the accurate analysis of bids. So this third area, which this has come up more and more, and I think that this is probably the biggest, unfortunately, I want to say problem, but this is the biggest misleading area in purchase services spend these days, is these broad and irrelevant benchmarks. And, purchase services spend, just like your PPI spend, you need to go down to that component level, but the service line item level. And the only way to benchmark is on the line item basis. And so we're hearing more about, we've benchmarked, we're getting benchmarked from our, let's say again, our dialysis spend by bed size. So we've got a benchmark of being able to analyze our dialysis spend by bed size to other hospitals. And I often say, it's my first comment out, is you wouldn't benchmark your PPIs by bed size. I mean, that would never happen, right? So why are we looking to benchmark by bed size for dialysis, or for wound care, or for dietary, or net patient revenue? Those factors do not have a correlating analysis. And even if they were to give you some sort of directionality, you would still have to go to the invoices. So we say, just go right to the invoices, get line item benchmarking. And I'll tell you what the problem is. If you think about it, benchmarking by bed size, which bed size is it? Is it staff bed? Is it Medicare beds? Occupancy? I mean, we had a hospital, had 70 beds. If you looked up their bed size, let's say they had 370 beds, but they kept 70 beds as an office. And so who's determining, what bed size? And so, this is unfortunately, a bad metric. It's an irrelevant metric, and it's causing harm, because if you say, well, there's no opportunities because we compare great on bed size for wound care, or we do great in bedside, compared to food services, you're missing out on this opportunity by not going to the invoices and analyzing the details. It's such a dangerous metric, because hospitals need cost savings now more than ever, and companies are trying to create broad benchmarks. This is not purchase services is not for the faint of heart. This is difficult, roll up your sleeve work, and it's not work for throwing up an easy benchmark by putting one number and divided by the other. This work requires deep line item invoice analysis and deep subject matter expertise. And so, I can't stress enough that, where you get your benchmarks, who's doing the thinking behind those benchmarks, why are they doing it? Is it easy to create, we have a benchmarking tool. Is it easy just to put something in a tool? Or is it truly meaningful? Benchmarks have to be accurate. They have to have specificity. You've got to be able to take that benchmark and negotiate with a vendor. Could you take a benchmark based on bed size and take that to a vendor and renegotiate it? Of course you couldn't. Could you take a detailed line item strategy, with a thoughtful plan and an explanation on why those line items should be priced differently? That's absolutely. So I'm very passionate about this because I can't tell you how many hospitals are having a false sense of security, or they're not looking at these areas of spend because somebody said, based on bed size, based on net patient revenue, that benchmark is a good benchmark. And the fourth area is the contract's completed, so there's nothing more to do until renewal. So Pandu, I don't know if you want to talk a little bit. I think it'll be nice to hear from all of us as we kind of wrap up on this podcast. You do a lot of work with our technology and extracting those line item details and programming the contracts in and providing a measuring and monitoring service. So you see it probably more than any of us, why we've just completed the contract a year ago. There's 2 years left in the agreement. So you know what, we're going to skip reviewing this versus we need to review our contracts every year. But can you talk a little bit about what you see and, maybe why that might give somebody a false sense of security, just thinking I did that contract and we have 2 more years left on it and we'll review it then?
Yeah, I think it's common for us to get a contract and constantly monitor it by extracting invoices, and probably 95% of the time that we extract invoices just to check these contracts to make sure they're aligning, there's issues. And a lot of the issues, we run into sometimes might be because they just haven't been reviewed or they haven't been coded to the contract correctly. And other times it's just because they were never coded to the contract correctly in the first place, or the vendor's just not aware of it. So, it's really common to see issues, midterm, which is why we, tell our clients that we highly recommend that they review their agreements, even if they're not up for renewal right away, because it's extremely, valuable to them.
Yeah, and I love that, you're talking about the, having those reviews during term. We're used to saying, okay, we have a 3-year agreement, 6-9 months before the agreement, we're going to assess it, review it. And sometimes if you are doing a deep analytical historical review, you'll find errors, and then you probably find service spent off contract. You can't go back and get a credit for off contract spend. You possibly could for the credits, but if you were having a process where you were evaluating your contract performance quarterly or annually, you're going to catch these things in real time, and you're going to keep those cost savings, and you may even be able to go even further from the initial cost savings that you identified. Rich, you want to speak a little bit about, contracts completed, and we're going to wait until the renewal?
Right, and there's 2 parts to this. It really, from a responsibility standpoint, when there's a sourcing event and, the supply chain is working with the department and they're successful in putting a new contract in place, and then the focus goes to other agreements, right? So then it goes back to the department, but the department has a lot that they have to manage and oversee. So there's typically what we find is there's a disconnect just on the managing of the contract and the pricing. just because you do have the two, and then you also have AP. So it's usually shifted of who's responsible for managing the agreement. And when you start to get, the scales of some of these healthcare organizations and the amount of spend that comes through, it's just impossible for one group to do it. And especially when that group is not their main focus. So that's when we see a lot of these challenges are, managing it. And then there's a whole industry now on just reviewing contracts and reviewing invoices, and it's AP audit, but it's really these AP audit firms. It's failure work. It's just because, the department, finance, and supply chain collectively, from a management of the contract and management of the invoices, the management of the deliverables on the agreement are just not taking place at the level that it should, and therefore there's a whole niche, service now for AP audits that are for the foreseeable future, just because of the amount of size and volumes that are coming through on the invoices.
Yeah, and it's so true, Rich, right? So we've built into, particularly on the purchase services side, we've built into knowing that they're manual to reconcile, unless you work with VIE. We've got an automated way to do that, but they're basically manual to reconcile, and these reviews, line item reviews, can't be done. Some of these invoices have tens of thousands of line items, so it's physically impossible really for people to know what every single line item price should be versus a contract, so they usually analyze it by 10%, give or take. If they see a spike, then they're going to dig into it. And now we've built into the industry AP audit firms who have to help us with failure work, and we say, we want our hospitals to be high-performing hospitals with high-performing contracts that are measuring, monitoring real time. There's a fee to pay for that failure work. It's a lost money, opportunity at the time when you're overpaying, and then paying for another company, and then the resources to support that company. So there's a big cost to pay for not having a measuring and monitoring system. Yes, there is an investment, but that investment is far less than having to lose the money, then trying to recapture it, and then pay to recapture it.
Right, and just one other piece on that is that a lot of those AP audit firms are not understanding the complexity of some of these agreements, and there's opportunities that are missed from a credit standpoint or from an adjustment. Plus, you're looking at what is off contract, because they're not really looking at what products are off contract. They're just looking at what's on contract as the incorrect pricing. So there's a whole other piece there. If you rely on AP audits alone, you're missing out on a lot of cost savings opportunities and credit opportunities.
Yeah. So we say let's have real-time optimization, real-time reviews, real-time ensuring that items are on the contract, real-time ensuring that the price is accurate. You want to operationalize those purchase services spend, so you have real-time measuring and monitoring, and you will capture a tremendous amount of cost savings, picking up on errors. I mean, I don't think we can overstate how important it is to have a real-time measuring and monitoring program on your purchase services spend.
And just think, if all the half of your spend, half of your non-labor spend, you have, if it's off by a penny, immediately supply chain knows, immediately AP knows that it's a red flag. It has to be looked at, and before it gets paid, right? So any type of price increase, any type of mistake on the invoices on sutures, endo, implants, all your supplies and PPIs immediately. But on the purchase service side, you could go months, years with an incorrect price, and no one will know about it.
Yeah, we could probably give everybody so many stories, but the one that always pops up in my head is we were performing, helping a hospital renegotiate one of their medical waste agreements. So our process is always going back 12 months for the invoice data so that we can see the real utilization, so we can benchmark with line item detail. But we were looking at the line item details, and there was one line item that had 10 times $3,400. It was a $34,000 price buried into what regulated medical waste invoice, and it just said price increase. That invoice was paid. But to Rich's point, if that had been a PPI or somewhere else, that capital, that would have flagged $34,000 not to pay. This invoice was paid, and what's fascinating is this hospital has a categorization tool that they use, and that month it was a dip. It was the lowest month out of all the spend. So nobody would even have looked in that month because the categorizations they're just directional. So it was a dip. It was one of the lower months of the year, and yet there was a $34,000 billing error that was paid. And so if you think of compounding that by 8, 9, 10, 20, 50 times all over the hospital and all these different purchase services, you see the opportunity where measuring and monitoring and putting a program in place is so essential. You want to be real-time monitoring your purchase services spend. So I just want to thank you for listening today. It was great, having Pandu, Bryan, and Rich on the podcast today. We've, enjoy talking about opportunities in our work, to listeners. So you'll hear us a few other times having these discussions, and we're also going to have a few other of our analysts and subject matter experts. We have a telecom IT a guest from VIE, Jacqueline Oberst, who will be on a show in February, as well as guests from hospitals and within and outside the industry. So thank you for joining us today.
Thank you for listening to this episode of the Healthcare Leadership Experience. If you enjoyed today's show, please leave us a review. Your reviews help other healthcare leaders find this podcast and see the value that it provides. If you're a healthcare leader who would like to be on the show, or if you'd like to listen to more episodes and view our show notes and resources, please visit us at thehealthcareleadershipexperience.com. Thank you for listening, and we'll see you again next week.